Welcome back to another video where we are going to discuss reabsorption, filtration, along with how ADH and aldosterone is affecting the RAAS system, the RAS system. First, we're going to start out with a little anatomy. Over here, we have our kidney. With our kidney, I just want to focus on a few parts. So we have your different arterioles over here, which lead to your afferent arteriole, leading to your glomerulus, which is then going to be, which we're then going to focus over here in a second. And that is going to allow filtration to happen, which will then empty out into the urethra, which allows you to pee. All right, with this being said, this is what the inside of that nephron looks like. You're going to have the tubule. You're going to have the afferent arteriole coming up and into the Bowman's capsule, in which and then you also are going to have your efferent arteriole leaving. And this is going to be important as these efferent and afferent these peritubular capillaries over here are going to be all throughout here, allowing different reabsorptions to occur. After you leave your Bowman's so in your Bowman's capsule and just beneath it is where you're going to have your filtration occur. Then down here you're going to have your proximal tubule, then you're going to have your descending tubule, then your loop of Henle, your ascending tubule, your distal tubule, and finally your collecting duct. So, and just for you to understand what these drawings look like, I'm just going to show you. So here we have our glomerulus, we have our Bowman's capsule, which is this, and then we have proximal tubule, afferent arteriole, efferent arteriole. So just stick with me there as we continue to move on. Yeah, and on the opposite side, so this is your cortical medullary nephron, and this is your juxtamedullary nephron. Alrighty, and here you have your cortex, then your medulla, and then your vasa recta. That will become important a little bit later as we discuss what's going on. First thing we're going to discuss is explain how solutes in water are reabsorbed in the kidney tubules, include the reabsorption of sodium, glucose, water, chloride, calcium, potassium, etc. Include your discussion how the various solutes are reabsorbed, and the concept of renal threshold and saturation. So over here, I'm just going to focus on this one a little bit. So right here, we have our Bowman's capsule, and down here we have our proximal convoluted tubule, as we showed earlier. And then we have our loop of Henle, and then our distal convoluted tubule. That's the ascending tubule. Your distal convoluted tubule and your collecting duct. So this will become important as we continue to dive into what is going on. Reabsorption occurs primarily in the proximal convoluted tubule, but it continues throughout the nephron, and it involves active and passive transport, which allow mechanisms to reclaim water and solutes from the filtrate back into the blood. So over here you're going to see how sodium, you're going to see sodium over here in different places. Sodium is the primary driver of reabsorption. It's actively transported out of the tubule via the sodium-potassium pump on the basolateral membrane, which is this right here. So this right here is the basolateral membrane. And the gradient that it creates allows sodium to enter from the tubular lumen, so it enters through here. Well, I should more show it over here. It allows it to enter over here through either symports, like this over here with glucose, or antiports, like this over here with hydrogen. Most sodium is reabsorbed in the proximal tubule, and as we see here, 70% of it is absorbed. And so just in the proximal convoluted tubule here, we're seeing 70% of the absorption of the sodium. And then others will be reabsorbed in the loop of Henle, the distal convoluted tubule, and the collecting duct. Next, we're going to talk about a little bit about the glucose. Normally, 100% of glucose is reabsorbed. Now, there are some special cases where glucose isn't reabsorbed, but we'll get talking about that whenever we talk about renal threshold here in a little bit. So just know that on a normal individual, 100% of the glucose is reabsorbed. Next, we have our amino acids, which are these right here. 100% of those are also reabsorbed, and it all depends on that sodium that is coming in. And then water, we see here that nearly 70% of water is reabsorbed here. Ooh, what did I do? I'm going to undo whatever that was and come back. And so the water is coming through and being reabsorbed. And then and it flows through reabsorption through these aquaporin channels. In the proximal convoluted tubules, they move through those channels, and not only that, but they also, in the collecting duct, the water reabsorption is then regulated by the ADH via other aquaporin channels, which we will hit on that in a bit. Oh, click. There it goes. Alrighty, next up, we're going to start talking about the chloride down here. With the chloride, it's reabsorbed passively following the sodium, so in the same direction, to maintain electroneutrality whenever the sodium is absorbed. So that way, it's not going to cause any problems there. And with that being said, it's going to be an anion that also is exchanged through there, so that way the chloride can come in. It's got to use that antiporter sequence. And then I also, where'd it go? But yeah, so that's the main pathway for that there. And another way just wanted to make sure I highlighted that water is also being reabsorbed right there as well through the paracellular pathway. As we see here, there's transcellular, meaning going through the cell, and paracellular, meaning going between the cells. And these cells are just called tubular cells. Alrighty, next up, we're going to talk a little bit about our calcium. Oh, where am I going? Alrighty. So calcium is reabsorbed in the proximal convoluted tubule. About 70-ish% is generally reabsorbed. And it goes through this paracellular. It is reabsorbed paracellularly as it goes between the channels. There we go. Perfect. And then in the distal convoluted tubule, reabsorption is regulate. We know that the reabsorption is going to be regulated by the parathyroid hormone. And that parathyroid hormone will allow the release of different hormones to cause different channels to open and different aquaporins, different porins to become available. Potassium, coming back over here, is also reabsorbed in the proximal convoluted tubule. It's also reabsorbed over here in the ascending tubule as the potassium is leaving. And the chloride is also doing the same as well. And with this being said, it's in the, and along with that is in the collecting duct, potassium is also not only being reabsorbed, but it's also being secreted as well, as it depends on what the body's needing. If there's more release of this ADH, antidiuretic hormone, is going to activate this G protein complex, which is then going to react with this, causing more water to be able to go outside. And as this is increasing, it's also going to affect the flow of our potassium. So anytime you see ADH increased, your potassium is going to increase, your secretion of potassium is going to increase. Alrighty, next up we're going to talk a little bit about renal threshold. So renal threshold, here, let me just make a new little thing here. Renal threshold is the plasma concentration of a substance when it first appears in urine. So glucose, that's generally around 180 milligrams per deciliter. And so anytime you see more than that, a higher number than this, that means you're going to see glucose in urine. And another thing with the renal threshold is each transporter has a max capacity, which we're going to call TM, max transporter capacity. And so if I'm just going to draw here a little transporter that glucose is coming in. So if glucose is coming in, if it reaches threshold, like if there's a lot of glucose up in here, it's going to become so saturated that it can't come anymore. So therefore, the rest of them will be excreted in the urine. And so that is another time in which you will see glucose in your urine, as well as whenever there's excess solute that cannot be reabsorbed. And for glucose, the saturation level is about, the TM, total max capacity, is about 375 milligrams a minute. So you can absorb a lot of glucose. It just can't handle anything past that. So as we come up here, we explain how solutes in water are reabsorbed in the kidney tubules, including the reabsorption of sodium, glucose, water, chloride, calcium, and potassium, and discussed how various solutes are reabsorbed, and the concept of renal threshold and saturation. Next up, we're going to discuss process of filtration, describing the filtration membrane in the renal corpuscle and the pressures involved in filtration, and discussing how blood flow may be regulated to the glomerulus, and describing what GFR is and explaining the principle of clearance and how it is used to estimate GFR. And we're also going to explain tubuloglomerular feedback. So first things first, we're going to talk a little bit about filtration, but I just want you to understand with this, we're going to be hitting on this little anatomy, and I just want to make sure you're aware. Whoops. This here is the glomerulus, and this here is the Bowman's capsule. Alrighty, so where the glomerulus and renal capsule are, we have a membrane known as a filtration membrane consisting of 3 layers. That's going to be your fenestrated endothelium, your basement membrane, and your filtration podocyte slits. In these different areas, it's going to allow only certain molecules can certain molecules and ions to pass through it, such as water. Here, let me write these down for you. Such as water, different ions like chlorine, calcium, potassium, sodium. Oh, that's not a K. And then it's also going to allow glucose, amino acids, and other small molecules. But it won't allow proteins and cells, which are also normally retained in blood. So these are the things that are able to pass through. Alrighty. With that being said, in our glomerulus and Bowman's capsule, we have different pressures. You have your glomerular hydrostatic pressure, you have your capsular hydrostatic pressure, and you have your blood colloid osmotic pressure. And your hydrostatic pressure in your glomerulus is around 55. In the capsule, it's around 10, and your BCOP is around 28. And so, there you go. So whenever you, in order to find out which direction you go, you gotta add up what's going where. So we know that our hydrostatic pressures are going, the pushing out. So this one is going out this way, this one wants to go in this way, and your BCOP is pulling in. So that will give you a total net pressure of about around 17. So it is around 17 out. And so with that being said, is that filtration of those three forces is what is allowing the water, ions, chloride, glucose, amino acids, and other small molecules to then enter into your capsule. Otherwise, they would just go straight back into your blood. And so it's allowing that filtration to occur. So you're losing those things from the blood as it enters into the kidney. Alrighty. Here we're going to talk a little bit about the intrinsic pathway of that regulates glomerular blood flow and maintain GFR. Real quick, I just want to touch on GFR. GFR means glomerular filtration rate, and that's just going to be the volume of your filtrate over a time. So it's going to be like milliliters over minutes. And oh, don't know why it's doing that. Okay, there we go. All right, and with that being said, we have our myogenic reflex, which is when the afferent arterioles constrict whenever there is high blood pressure. So that way it can lower blood pressure. So our kidneys are a little bit different than our vessels throughout our bodies, because they're going to do the opposite of what those do. Whenever the arterioles vasoconstrict, our blood pressure is going to decrease, allowing it to start to have that negative feedback. With that being said, this is how it works. As you see here, I drew the afferent arteriole. Whenever it constricts, it's allowing less blood to come in through here, which is going to decrease the amount of pressure that it can receive over here. And so with that, we just understand that it's going to be that, and whenever it dilates, it's going to increase the blood pressure in the kidney. So keep that in mind. And then efferent arterially goes back to the way the rest of the body does it. Whenever vasoconstriction happens, it increases blood pressure in the kidney because it's coming back. It's bouncing and coming back. Whenever dilation occurs, it's decreasing because it can then take a lot more at a time. Alrighty. So that's the auto regulation a little bit, is just whenever it's vasoconstricting and whenever it is vasoconstricting and doing that. We're going to talk a little bit about our tubuloglomerular feedback, which I know it talks about it towards the end, but I'm just going to talk about it right now. So this is when the macula densa releases adenosine and nitric oxide, in order to regulate our blood pressure. So our macula densa is located right over here. It's going to be connecting the capsule along with the afferent arteriole. It's going to be on the afferent arteriole, and it's going to detect sodium chloride levels, as it also is sitting close to the capsule and ascending tubule. Now, as it detects an increase in sodium chloride, it's going to release adenosine, which is then going to affect the afferent arteriole to vasoconstrict. And what did we talk about whenever it vasoconstricts in the afferent arteriole? Right, it decreases blood pressure, which is going to decrease GFR, as they are directly related. If we decrease our blood pressure, that's going to decrease our sodium chloride, which our macula densa is going to then pick up, which is then going to signal nitric oxide to be released, causing the afferent arteriole to vasodilate and then increasing blood pressure. And so this happens to help maintain our homeostasis, making sure that we are not going to be too high blood pressure, too low blood pressure, making sure that we can have different pressures within our capsule, making sure that we can filtrate and reabsorb properly. And then with that, right. And so this is a little using it through the nitric oxide. That's just making sure that everything works properly. Sorry, I don't know where my thought was going there. All right, just discussing a little bit more about GFR. GFR is generally around 125 milliliters per minute. And it's making sure that kidneys function properly. If something is wrong with your GFR, something is probably probably wrong with your kidneys, so that way you should probably get it checked out. Next thing we're going to talk about is our clearance. Here we're going to talk about this equation here. Clearance is going to be equal the amount of urine multiplied by the amount of urine, which is the V. Whoa, what is going on? Multiplied by the concentration of that urine over the plasma concentration in your body. So how this is taken is somebody's going to prick your finger, and they're going to measure the amount of plasma in your body. Then they're also going to take your urine, and they're going to measure the concentration of your urine and the volume of how much there was within a minute. And then they're going to put that over how much they measured in your blood, in order to find out what your clearance rate is, how much of that you're actually getting out of your body. And so just to show you an example, this is where your P of X is because it's in your blood. And then different solutes will pass through. And then this is the concentration of your urine. So these solutes that pass through can end up in here, and that will contribute to your clearance. And then your volume is just the amount that is taken out. So we have different clearances, and just making sure is whenever you filter it, you're going to filter small non-charged and unbounded proteins, which are not metabolized. And it's going to flow from your plasma concentration to your urine concentration. We're going to talk about inulin in just a minute. I first just want to touch on these. So just know that the general clearance of sodium is around 10. With PAH, it's around 170. And glucose, you shouldn't be having any because it should all be reabsorbed as we discussed earlier. Alrighty. So now we're going to talk a little bit about this inulin right here. Inulin is a small, unbound, no-charged solute in which all of it will come out. Not a single piece of inulin is still left in. So it'd be really nice to measure inulin, but inulin doesn't naturally occur in the body. But we do know that inulin is roughly around 125 milliliters a minute because we've given it to people and then we've tested their inulin amounts, so that way we can know how much is in there. And so the thing that scientists have discovered is that around the creatinine is excreted, is cleared about 127 milliliters a minute, which is very close to inulin, which is why whenever doctors take your clearance levels, they'll be measuring your creatinine, so that way they don't have to feed you inulin. Also know that as you increase reabsorbance, you're going to decrease clearance. And then whenever you increase secretion, you're going to increase clearance, because when you increase your absorption, that means you're decreasing urine concentration, which is decreasing clearance. When you're increasing secretion, you're going to increase urine concentration, which is increasing clearance. Alrighty. So we already discussed we discussed all this right here. We discussed the process of filtration, the filtration membrane in the renal corpuscle, and the pressures involved. We discussed how blood flow is regulated, and the GFR, then explain clearance and tubulo-glomerular feedback. Last but not least, what we're going to do is we're going to explain the RAS system, and then we're going to describe at the cell level what ADH and aldosterone does. And then we're also going to explain the loop of Henle, how it's established and maintains a renal modulatory concentration gradient, and explain how this gradient and ADH can work together to excrete urine of different concentrations. So first, let's go ahead and start off with the renin-angiotensin-aldosterone system. So whenever you have a decrease in your GFR, it's going to release renin. Whenever renin is released, it's going to go through a couple of steps that I've talked about in previous videos. But to just touch on it again, it's going to cause angiotensinogen to become angiotensin 1, and then we have something here called ACE, and then the ACE is going to convert the angiotensin 1 into angiotensin 2. Now, if we have an ACE inhibitor, that's going to block off, as I showed here, the angiotensin II, which is going to affect our blood pressure because, as we see here, angiotensin II goes to the brain dealing with thirst, releasing ADH, antidiuretic hormone. It's going to vasoconstrict, increasing blood pressure, and it's going to constrict efferent arterioles, increasing blood pressure, and releases aldosterone. Whenever you inhibit it, you're going to be decreasing the blood pressure, or at least not increasing it, as your body wants to do. Alrighty. So that's a little bit about what's happening there. The other things that will release ADH is like baroreceptors and osmoreceptors, and then something that will release the aldosterone is hyperkalemia, as your body will start to release more aldosterone due to that response. Alrighty. We're going to talk a little bit about aldosterone. So aldosterone, I'm going to make this one a little bit bigger, is it's going to bind to intracellular. I'm actually going to make that smaller. Oh, there it is. Intracellular mineral colloid, corticoid, sorry. Mineral corticoid receptors. Whenever it binds to those, it's going to increase your epithelial sodium channels, and it's going to increase your sodium-potassium pumps on the basolateral side. While these are on your apical side. So you're going to have your ENaX coming in here, and then your sodium-potassium coming here where the sodium's leaving. And so as a result, the sodium is more absorbed, and then more potassium is secreted. And this allows water to be retained more in the blood, because as we remember, our blood is on this side, and as our sodium concentration increases over here, our water is going to follow it. All right, now we're going to talk a little bit about this ADH right here. I'm just going to draw an arrow going up here. So ADH is released by the posterior pituitary gland. And it's responding to low osmolality. Sorry, not low osmolality, that's high. It's low blood volume. High plasma osmolality. And low blood volume and pressure. So it's going to be released more, and what it's doing is it's going to bind the V2 receptors on collecting ducts, which this activates, and I'll show you where in our drawings we have this. It's going to activate our CAMP pathway which is going to insert more aquaporin channels on apical side. And then water is then reabsorbed. And our urine is more concentrated. So just shown where that's happening over here. I have a better drawing of it down here. So here we have our ADH coming in, reacting. It's going to make sure that these channels get placed on here, so that way water can then be reabsorbed and and causing our urine to be more concentrated. As that occurs, our sodium is leaving more. Our potassium is still able to leave these channels, allowing it to be secreted more there. So it's really, the ADH is really a fine line between secreting more potassium and increasing water absorption. Next, we're going to talk a little bit about the loop of Henle and different kind of reabsorptions and different things that are happening. But first, I just want to explain that the loop of Henle, especially in juxtamedullary nephrons, it will create a hyperosmotic medulla, which will cause more different things to cross the membrane. So as we see here in the descending limb, we see the proximal tubule, which is right here. We have the descending limb and then loop of Henle, right? So the descending limb here is going to be permeable to water only. And so first, before I move on, as we go down our different limbs, we're going to see our solutes start to increase. Concentrations. Our solute concentration is going to go from 300 to 400 to 500 to 600. So as we know, water wants to follow the more concentrated area of solutes. So whenever our solutes leave our glomerulus into our capsule, it's going to be at around 300. So at first, it's not going to be, the water movement is going to be about even. But then whenever we get to the 400 region of solutes, the water is going to want to leave more. But the solutes are not leaving because it's not permeable. And so whenever the water leaves, the filtrate is becoming more concentrated, so it's increasing that concentration, which will then become 400. But then whenever it continues to move down the tubule, it's going to enter into the 500 range, and then more water will leave, increasing concentration to 500. And then in the loop of Henle, it'll barely reach the 600, but it'll still get there, to where it will then decrease to about, it'll then increase to about 600 as water moves up more. Now, whenever we get to the loop of Henle, these are when we start to have different solute channels. Now, solutes can move about back to the ascending limb. Solutes can move roughly around 200, concentration of around 200 at a time. And so we see whenever we start to ascend back up, these channels are going to open up, and they're going to allow for the resorption of sodium chloride and also potassium. And also potassium. And then the filtrate becomes less tonic, and it starts to decrease in its concentration. While this will continue to happen as it comes across more and more channels. So it's going to be less and less concentrated until we get to the point to where it is around the concentration of around 100 milliosmoles. And then we're not going to have any more channels for it, and it's going to move through. And as we have such a low concentration over here, we're going to have aquaporins all through this collecting duct, which water is then going to move out a lot. Alrighty, so as we Right, and then something I also wanted to just discuss that isn't mentioned in the video is right here is there's also a urea leaving from our collecting duct and going to our channels, our juxtamedullary area, so that way whenever it reaches such a low concentration over here, such a high concentration of solutes over here, the urea is then going to leave as well from there. Alright, and just making sure you know that in the absence of the antidiuretic hormone, the collecting ducts here will remain impermeable to water. Collecting ducts will remain impermeable to water, so these will not be going through, which means that we're going to excrete it, meaning we have very dilute concentration of urine. Alrighty. So we explained the RAS system, we described what happens with ADH and aldosterone, we explained the loop of Henle and how it maintains renal medullary concentration gradient. We explained how this gradient and ADH can work together to excrete urine from different concentrations. So I hope you join me next time, and just remember, this is key in our reabsorption because this allows us to be able to understand how things are going to move throughout our kidney. So join me next time for the next essay. Hope you liked it.